So today's session is about types of seizures in epilepsy, and by the end of today's session, hopefully you will learn about how to recognize types of seizures and stages of seizures. In particular, also how to differentiate between a seizure and a postictal stage. Also, what to do in the event of an emergency during a seizure, and also what can trigger seizures. All right, so before we talk about types of seizures, it's important to be on the same page about what a seizure is. So a seizure is an individual event or a spell or an episode of neurological symptoms due to an abnormal surge of brain activity. You can think of this as an imbalance between the brakes and the accelerators of electrical activity in the brain, or almost like a short circuit. Epilepsy, on the other hand, is a brain condition or a brain disorder where a brain is prone to recurrent, unprovoked seizures. And the condition includes not only that risk for recurrent epileptic seizures, but also the consequences on the brain structure and physiology, the brain function, and also its impact on a person's life. So over time, the words and labels that we've used to describe seizures has changed over time. And don't worry about this graph here too much. It's just to show you that over the years, we've changed the words that we've used over time. And today we'll focus on the current kind of dictionary of words and system of labels that we use to describe seizures. And it is more structured and straightforward. You can think of it as having a first name, okay, and a last name to the description of a seizure, where the first name describes where that surge of brain activity is occurring, okay? And then the second name to the label describes what an individual is experiencing during the seizure, okay? This is just a little bit another way of looking at the system, okay? And so the two main branches to the naming system are whether or not a seizure is focal in onset, or that surge of brain activity is occurring in one location, one focus in the brain, or if the seizure, the surge of brain activity is occurring in a more generalized manner, a generalized network of the brain, so generalized onset, okay? Of course, sometimes we just don't know that, and so there is also a third category of unknown onset. But within the umbrella of focal onset seizures, we also break things down into whether or not a person remains aware or if they have a loss of awareness, okay? And then we describe whether or not there are motor or non-motor features or symptoms during the seizure. And we'll get into more of that on on the later slides, okay? And that depends on where that focus of surge of brain activity is occurring. And you'll see here that I put a couple of terms in red boxes here, which are some of the older terms. So under the umbrella of focal onset seizures, focal onset aware seizures used to be called simple partial seizures. Whereas focal onset impaired awareness seizures were called complex partial seizures, okay? Now, moving on to the generalized onset category. So these generalized onset seizures are associated with impaired awareness, okay? And then we break them down into whether or not they are motor seizures or non-motor seizures. And the motor seizures, the most common type that you'll probably picture when you think of the word seizure is a generalized onset tonic-clonic seizure. Okay, and in the old words, people would have called this a grand mal seizure. On the other hand, there are non-motor generalized onset seizures as well, and those are called absence seizures, and that kind of breaks our rule here of having a first name and a last name. These are just called absence seizures. In the old terms, these would have been called petit mal seizures. Okay. So let's talk a little bit more about focal onset seizures. So again, the surge of brain activity is occurring in one focus in the brain, and that can spread to neighboring brain structures. The symptoms that you experience depends on where that focus is. But just to go on with this kind of animation a little further, sometimes that brain activity can spread to the opposite half of the brain, or sometimes it can involve more general networks of the brain, okay? And when that occurs, a focal seizure can become generalized, okay? But let's focus, pun intended, let's focus on focal onset seizures a little more here. So what you might experience depends on where that focus is in the brain, okay? So for example, if that focus is in the frontal lobe, you may experience things like jerking, okay? Or more complex movements like rowing or kicking and bicycling, okay? And the jerking, if it is jerking, it can spread along the body, okay? When that focus is in the parietal lobe, you may experience numbness or tingling. That may stay in one body region, or it may spread to neighboring body regions. In temporal lobe seizures, these are harder to notice for people sometimes. Also often hard to notice from the outside too, by onlookers. But a person might experience things like a rising sensation in their stomach, as though they're on a roller coaster. They may feel heart racing or hair raising sensations. They may experience something memory related. So something called déjà vu, which is a sense as though you've been there before, or a sense of familiarity when you're experiencing something that's not familiar, it's a situation that you've not really been in. On the other hand, something opposite can occur called jamais vu, something you're experiencing something you have experienced before, but you feel as though it's new to you. People may experience emotional symptoms like fear or panic, or things like taste, smells, or sounds. And you might remember, some people might remember the Canadian Heritage video back in the day where a person said that they smoked burnt toast, right? So that would be an example of a focal seizure. In more kind of back parts of the temporal lobe, people can experience complex visual experiences, okay? So things like hallucinations, visual hallucinations. With occipital onset seizures from the back part of the brain, people will see some more simple visual experiences. So things like flashes or lines or waves and shapes that might spread across a person's vision. Something that's important to keep in mind is that depending on where the seizure focuses, what an individual experiences is going to be stereotyped, meaning that across episodes, the character of what the seizure is for that individual will be similar. Okay, and in terms of timing, these seizures will often last for at least several seconds to several minutes, usually less than 5 minutes. Okay. Okay, and now let's move on to generalized onset seizures. So with generalized onset seizures, the surge of brain activity, we do also think that it still starts in one spot, but it rapidly involves networks of the brain, okay? And by involving big general networks of the brain, usually people have no warning before these seizures occur. If there is some sort of warning, that raises some suspicion for whether or not a person actually experienced a focal onset seizure before it generalized. But with generalized onset seizures, again, there's usually no warning, or there's something vague, like just a dizziness or a warm feeling. Then the other features of a generalized onset seizure can be non-motor or motor, as we mentioned earlier. The non-motor aspect is loss of awareness, okay? And it may simply just be a loss of awareness episode in the case of absence seizures. And I'll show you a video a little later to get a sense of what that means, okay? With motor features during a generalized onset seizure, people may fall, they may collapse, they may have jerking or stiffening or shaking of the body, of both sides of the body, and rhythmically. And a little later during the seizure, usually people can have other things like frothing at the mouth or heavy breathing. They may bite their tongue. They may lose control of their urine. And then after the seizure itself occurs, people, the brain reboots, so to speak. And that is the postictal state where the brain is rebooting, okay? And we'll explore that a little further soon. First, let's just watch a couple of videos, and you can find some helpful videos on Epilepsy Toronto's YouTube channel, okay? And there are other good organizations out there, like the Epilepsy Foundation, and you can see some videos to get a better understanding instead of just hearing the words here, okay? But here's a video of a generalized tonic clonic seizure, okay? So hopefully you can see this and hear this. The sound's not as important. But this individual, this young man, in the middle of a conversation has the onset of loss of consciousness, and he falls.
Excuse me, ma'am.
He would have fallen if his friend was not there. And you can see that he's having convulsive activity now, so stiffening and jerking and shaking. So there can be a tonic phase, which is the stiffening. Yeah, there's some extra tips here that are helpful, and we'll review this again as well. But stay calm during the seizure. Try to time the seizure.
It's not an emergency.
Sometimes during the episode, things can feel like they last a lot longer than they really do. Here you see that the young man is jerking, and during this phase, the person can bite their tongue. And a few tips are to not physically or forcibly restrain the individual, and also don't put anything into the mouth.
Make sure he's safe and there's nothing around him where he can harm himself.
And yes, try to keep the area clear so that he's safe. And again, yes, there's a clonic phase where there's jerking. And if you can, try to place the person into a safe position and support the person's head and body, if possible. And yes, try to roll the person onto their side into a recovery position. And I'll show you a picture of this a little later. Towards the end of a generalized seizure, a person can, usually it would be urinate, but sometimes defecate as well. Okay, and then yes, after the seizure itself, a person will recover. Okay, so I'll just stop this video at this point. Similar to the focal onset seizures, generalized seizures will also last often for a couple of minutes. As a general rule of thumb, usually less than 5 minutes though, okay? And we'll get into that a little later in terms of reasons to call EMS and 911 if the seizure is lasting longer than 5 minutes, being one of the reasons, okay? Okay, so, oops, sorry about that. Okay, so sticking with generalized onset seizures, here is a nice little video of absence seizures. Okay, so generalized onset impaired awareness seizures, non-motor seizures. Okay.
This girl has absence seizures, and you will see her have one while she's talking.
Because he can be as heavy as ever.
And there's a real blankness, a vacant look in the eye, and then all of a sudden they're right back with you and able to engage.
Absence seizures can be mistaken for daydreaming. One of the hallmarks of absence is that the seizures happen many times in a day. Sometimes they're so fleeting, they're easy to miss. This boy is having frequent but very brief episodes. You can see his eyes flutter up. He's out of touch. Then he becomes fully aware again.
Yeah, so that's a nice little video, and the audio explanation is good too. So these seizures are often very brief. They can be seconds or even fractions of seconds at a time. And the person who is experiencing the seizure might not be aware of it at all. I mean, during the episode, they're not aware, but even after the fact, they don't realize that they had a seizure. And people blank out, and return rapidly back to consciousness, and they can re-engage. Sorry. They can re-engage in the conversation or activity that they were just engaged in.
This girl.
Okay, so keep that in mind and contrast that to focal impaired awareness seizures, so focal onset seizures with impaired awareness, because these sometimes can be confused with one another.
You can see in looking at the chart, we're looking at least a 10% increase from our first quarter to our second.
Adam?
So this person is staring off blankly, they're unresponsive, and you can see his hand, his left hand there is performing some automatic movements, some rubbing or fidgeting.
You're okay, Adam. You're fine, you're fine.
Sometimes you'll also see actually the opposite hand stiffen into an abnormal posture. Yes, and sometimes other automatic behaviors can include lip smacking or wandering. And unfortunately, sometimes this can be quite stigmatizing because people will think that people are intoxicated.
It's okay. You're okay.
Do you need help? Do you need me to call 911?
You're okay, Adam. Okay, do you mind pushing back the chair, please? Thank you.
And similar to the generalized seizures, you want to try to make sure that the person is safe, but you don't necessarily have to forcibly restrict their behavior, but move things that are dangerous out of the way and, if possible, guide them out of danger.
Fine.
Okay, in this case, usually a person realizes that something was wrong, that they had missed a period of time, okay? And people can take some time to recover from this, again, as the brain is rebooting, so to speak. They may feel a little off, they may feel a little nauseous, they may have a headache, okay?
Guys, this happens to me sometimes. I have a...
Okay. So I just want to explore this kind of difference a little bit more, okay? Focal onset seizures with impaired awareness versus absence seizures, all right? So focal onset seizures with impaired awareness can happen at any age, whereas absence seizures will often start in childhood or adolescence, okay? And then may continue into adulthood. The character of the seizure, as we were just talking about, right? So a focal onset seizure will, sometimes there is a aware period or prodrome or aura, and they may feel things like deja vu, smell or taste, or a rising sensation from their stomach. As you recall, these were the characters from the temporal lobe, okay? And then sometimes people might notice that a person's eyes or head deviate or move to one side, and some automatic movements can occur, okay? And then there's a loss of awareness during that period, and then a person takes at least several minutes, sometimes longer, to recover from this. On the other hand, with absence seizures, these happen suddenly, like a light flickering, so to speak, and there's no warning, and people recover back to the conversation or the activity that they were doing very rapidly. They may not be aware at all. Timing-wise, the focal seizure will last usually a minute or two, or longer, less than 5 minutes. Whereas the absence seizures are briefer. They can last several seconds, less than a minute, or less than 30 seconds often. Tests can be helpful to distinguish these. So sometimes focal seizures with impaired awareness will have abnormal imaging, so some focus or source for that brain activity, that surge of brain activity. Whereas with absence seizures, usually we don't get any clues from doing head scans, okay? The EEG can be very helpful if we capture some abnormal waves between episodes, or better yet, if we actually capture an episode. That can be very telling as to whether or not a zoning out episode is a focal onset seizure with impaired awareness versus an absence seizure, okay? And some of the techniques during the EEG that you might be familiar with if you had one is hyperventilation and photic stimulation, which can sometimes bring out the abnormalities that we see associated with absence seizures. Okay, so let's explore a little bit more about stages of seizure. Okay, so sometimes people will experience a warning phase or an aura. Oftentimes, though, this is actually a focal aware seizure. Okay. But some of the features will, depend again on the focus, that source of abnormal brain activity. So it can start with a rising feeling in the stomach, the sense of deja vu, smell or a taste, or an emotional feeling of fear or panic or joy. It may be something not as easy to describe, like a wave going through the body or the head. There may be some focus or focal localized stiffening or twitching or jerking that may spread along the body, or a spreading numbness or tingling along one side of the body. Or there can be visual experiences. Okay. Then with the ictus, which again, that can be the ictus, meaning the actual seizure event, right? If it is a focal seizure, you may experience any of what we were just talking about there, okay? However, the seizure can progress to involve loss of consciousness or awareness, loss of speech. There may be some automatic movements, and then there may be motor features with the seizure. There can be falling, twitching, jerking, stiffening, convulsions, right? Okay. Other things that can be helpful to try to pay attention to during this phase are whether or not the eyes or head are moving to one side, and if the stiffening has a pattern to it, if it starts in one spot and spreads or not. Okay, and then the two main phases for usually during a generalized seizure are the tonic phase and then a clonic phase. So a stiffening and then a jerking phase, and then there's relaxation of the body, and then a person recovers. And so the ictus will last for, again, often almost always less than 5 minutes, okay, usually a couple of minutes. And then the relaxation and recovery phase is the postictal state, which varies. It can be a few minutes, it can be 10 or 15 minutes, or longer. Sometimes people will have some still ongoing kind of grogginess or achiness, depending on the extent of the seizure for the remainder of the day or even a couple of days. But the postictal state is the recovery of the brain. People regain their bearings, regain their orientation. The muscles may be fatigued or sore. weakness might recover in a pattern opposite to when the jerking started. If the jerking spread in a particular manner, the weakness might recover in the opposite manner, and that's something we call Todd's periosis. Okay, sometimes people will have trouble with their speech during this phase too. So it's very important to know what to do during a seizure, right? Okay, so for caregivers, try your best to stay calm. Okay, it can of course be very unnerving to see this happen, right? But try your best to stay calm during the event and stay with the person and let the seizure run its course. Try your best to keep track of the time, because again, oftentimes things feel like they last a lot longer during the episode itself. Try your best to keep the person safe. So remove sharp objects around the area. If they're wandering or moving around, try to guide them to safety. If they have fallen, if they're on the ground already or on the bed or a sofa, try your best to reposition them if possible into the recovery position. So that's on this picture up here, okay, in the top right, onto one side, and you can use one of the knees, the top knee, to prevent the person from flipping over to the front, okay, and you can use the upper hand as well to sort of cushion or as a little pillow under the head, okay. You don't have to forcibly restrain the person, okay. They may become more agitated with that, okay. And although people used to think it was a good idea to put things in the mouth so that people don't bite their tongue or swallow their tongue, it's not such a great idea, because people can break the thing that you put in the mouth and choke on that, okay. So don't put anything into the person's mouth. And then as the person recovers during the reboot phase, the postictal phase, reassure them and keep them calm and keep an eye on them, okay? When is it that you should call the ambulance? When should you call 911? So really, the rule of thumb is if you feel uncomfortable, you would not be faulted to call 911, of course, right? Okay, especially if it is a first-time seizure. If the person has sustained an injury during the seizure, so if there's bleeding, if sometimes fractures or dislocated joints can occur, certainly those are reasons to call 911 too. If the seizure itself is lasting longer than 5 minutes, okay, or if the person's not recovering back to themselves after the seizure appropriately within at least 30 minutes to an hour or so, they should be moving towards back to themselves, okay? If they have more than one seizure in a row, if they're not recovering back to themselves between the seizures or after the cluster of seizures, that would be a reason to call 911 too. Certainly if breathing is irregular, that would be a reason to get help too, okay? If the seizure happened in water, definitely get help, okay? And then in certain people, if the person's pregnant, if they have diabetes, or if they have a fever, okay? So the last slide today is about what can provoke a seizure, okay? Some things you don't necessarily have control over, right? If you sustain a head injury, that can provoke a seizure, or if you suffer a bleed in the brain or a stroke or things like that, that can certainly cause a seizure. If you're fighting an infection, if you have a fever, that could be a provoking cause. If you have very high or very low sugars or salts in the blood, okay. Some women find that seizures can cluster before or during their menstruation period. Some things you do have control over, so ensuring that you have good sleep quality and hygiene. Some people are sensitive to flashing lights, okay. Alcohol, so abstaining from alcohol is absolutely the best, okay, but in particular, coming off of alcohol, withdrawing from alcohol suddenly, or sudden binges in alcohol are most risky. Other recreational drugs, mainly stimulants, okay, should be avoided. And then other medications that you might be on or need to take for other reasons can lower the seizure threshold, or in other words, increase your risk for seizures. So some antidepressants, antibiotics, antipsychotics, okay? And of course, if you are on seizure medication to prevent seizures, if you miss the seizure medication, if you forget to take it, that can be a cause for seizure too, okay? So that's actually all I had today. Took a little longer today, I guess, from the hiccups, but I just wanted to also put a little announcement here for those of you interested in having a say in research priorities. I've been involved in this priority setting group, and we have a survey going on right now until March. And the website is here, braininstitute.ca/epilepsy-BSP, okay? And there's a survey where you can pick what you feel are priorities for research, okay? And we'd be very interested to have your participation in this. And thank you.
Thank you, Dr. Chen. So I do see a few questions in the chat box, so I'm going to read those questions out for you so that you can answer. So the first question says, may I ask, post-seizure, you mentioned that speech may be affected. Speech may be affected several days following. At what point is a cause for concern? Is Dr. Chan there? I see him, but I don't hear a response.
Sorry, I had myself muted, so I was talking to myself there. So I'll just say that again then. So if the speech impairment is lasting for a day or longer, that's certainly something worth seeking attention for, okay? So the speech impairment after a seizure will usually last for a matter of several minutes, okay, or 10 to 15 minutes or up to 30 minutes to an hour, okay? And there should be improvement over that time period. If it's lasting longer than that, it would be worth seeking attention for that. The things that can last longer for the remainder of the day or even afterwards could be things like headache, soreness, achiness, fatigue, okay? Or some difficulty with concentration and memory, okay?
Thank you. And another question. So you mentioned that 911 should be called if there is high fever after a seizure. Can you please elaborate? We suspect that the fever is triggered by seizures.
Yeah, that's true. That's true. Fever sometimes can occur as a result of seizure, okay? More so if fever was happening as a cause for the seizure, right? Okay, that's certainly a good reason to seek medical attention, because you may want to ensure that you're not dealing with a brain infection, okay? So if you find that there is a fever after a seizure, after the fact, if it's something that you think you might not have noticed beforehand, then yes, if you feel uncomfortable, seek medical attention, okay? But if you find that the fever is just after the seizure, the person's recovering, you can take the temperature again and see if it normalizes. If that's the case, then not so worrisome, okay? If it's persisting, then definitely seek medical attention.
Another question, if there is trouble with speech, does it ever mean accent changes?
Sorry, could you see that again?
If there is trouble with speech, does it ever mean accent changes? Some change in the way you sound or you speak?
Oh, yeah, yeah. So we sometimes hear about accent changes or even like a reversion back to one's own first language, so to speak, right? That can happen with things like stroke sometimes. With the recovery phase during a seizure, okay, sometimes you could see things like that, okay, and again, that should be a matter of kind of minutes to several minutes, half an hour, an hour, and there should be recovery to that.
Can a person have more than one type of seizure?
Yeah, the short answer to that would be yes, right? Okay. But usually the one individual person should have the same kind of combination of seizures, okay, if they do have more than one type of seizure, right? Epilepsy is quite a many-faced condition, right? And people can have epilepsy for many reasons, okay? So some people may have more than one focus for a seizure, okay? And that could lead to more than one character of a seizure, okay? And then some generalized seizure conditions. Generalized seizure conditions meaning ones that you were born with, so to speak, or your brain was set up like that. Some of those conditions are associated with more than one type of seizure. So, for example, a combination of absence seizures as well as generalized onset tonic clonic seizures and myoclonic seizures. Just little brief jerks. That combination of that trio can be seen in a condition called juvenile myoclonic epilepsy. Okay, so that's the longer answer, I suppose. Yes, an individual can have more than one type of seizure, but it should be the same sort of complement or combination of seizure types in that one individual.
Is stress not identified as a potential trigger?
Yeah, stress can be a trigger as well. It's much more of a challenging thing to nail down, of course, right? Okay, but extreme stress can people often do report that is something that is kind of leading up to a seizure. Okay. But it's not something that we necessarily want to write off a seizure to, right? But from stress alone, right? Okay. And to some extent, stress is not something that's so easy to eliminate either, right? Okay, but stress is certainly something that you want to try to recognize and manage if possible too, okay?
Okay. So can an aura ever feel like a shiver?
Yeah. In medicine, there's, we never want to say never, okay? In life, we never say never, okay? But that would not be a common aura, I would say, okay?
Okay. Yeah. My son has tonic clonic seizures in his sleep, usually lasting 5 minutes. The postictal phase lasts 45 minutes of aggressive behavior, yelling, sometimes hitting things, wandering, and trying to get out of the house. I've just been told that it may be the aftermed I administer, lorazepam, could be causing the long aggression afterwards.
Yeah, that's certainly something that's worth exploring with your neurologist or whoever is managing your son's seizures and epilepsy. Okay, so there's a lot to explore in that sort of statement there, right? A few things that I would just pick up upon would be that we try not to necessarily use lorazepam too readily, right? Okay, we would consider administering Ativan or lorazepam. Usually, the guidelines would be if a seizure is lasting more than 5 minutes, okay. If a person is not recovering between seizures with a cluster of seizures, okay. If a person has had more than one seizure within an hour, right? And those kind of timings and numbers might be a bit of a moving target depending on your exact situation and how frequently and how long seizures are lasting for that individual, okay?
Can auras or seizures cause laughter, or is it a post-seizure symptom?
Yeah, so yes, there are some seizures that involve laughter, right? Okay, so the fancy term that we use is called gelastic seizures, right? And they involve laughter, yeah. But it could also be a post-seizure symptom. Yes, it could occur in the postictal phase, not very typical, but if a person's not quite themselves and they have a little bit of mood alteration following the seizure, they might inappropriately laugh or respond emotionally to the situation.
How common is it for focal impaired awareness seizures to last more than 10 minutes?
Yeah, uncommon. Okay, not common. So the challenge sometimes is that sometimes people do have clusters though, right? Okay, and it can be hard to pinpoint the start and stop of a focal impaired awareness seizure. Okay, but if they are lasting longer than 10 minutes, that's definitely something to explore with your provider.
And the last question I can take, because we're out of time, is it possible to have permanent brain cognitive function impairment, example, memory impairment?
I suppose the question is if is it possible to have that sort of impairment following a seizure. So no, the injury should not be permanent from an individual seizure. There should be recovery, again, over the course of several minutes or 30 to 60 minutes or the remainder of a day, okay? Again, it depends on the type of epilepsy, though. If there's a cause for the seizure, if there's a focus for the seizure and for the epilepsy, then that may be a cause for memory impairment. Sometimes if seizures are happening frequently enough, that can impair a person's memory too. Okay, yeah, it's a kind of a bigger topic to talk about. But if a person's having, for example, very frequent absence seizures, those little flickering light episodes that we saw a video of, for example, if the brain's not online to record memories, then they won't be able to recall those memories. So that would be an example of how seizures themselves can cause memory impairment.
Okay, thank you so much, Dr. Chen,